Thank you, Dr. Le Roux, for giving up your time today to answer some questions on male fertility in recognition of World Fertility Day. The questions were posted to IFAS's Facebook page by our followers, and I know your input will mean a lot to them. Please, can you start off by telling us a little bit about yourself and Cape Fertility Clinic?
Sure. Thanks so much, Saskia. It's absolutely wonderful to join you. And I really appreciate all the wonderful work that IFASA does for all the many infertile couples that need assistance around our country. We're grateful for your assistance. So my name's Paul Le Roux. I'm a fertility specialist at Cape Fertility, which is a private fertility unit in Claremont in Cape Town. And we're quite a big IVF unit, and we do all aspects of IVF treatment, including looking after patients who've got male infertility, which is our topic today. So it's a very important topic, and many patients are affected by this. And I'm very happy to discuss the topic with you. Thank you.
Excellent. Okay, great. So let's launch straight into the questions. If I had never had an injury to my groin area, nor have I had mumps, could I still be infertile?
Yes. So when we do infertility investigations, it's important to do these investigations because you can't always assess whether somebody has got a fertility problem just based on the history. And it may be helpful if somebody's had a history of mumps infection to their testis, which can damage the testis. Most of the injuries to the testis actually don't have any effect, and all the guys can remember when they've had an injury to their testicle, but most of the time it actually doesn't have any effect. But we need to do the actual detailed investigations, and that basically the first step would be a semen analysis, and this is just done in the IVF laboratory, and it's an easy test where a sample is dropped off, and we can basically look at various parameters in the sperm, and that will tell us actually whether there's a real problem or not in terms of infertility.
Okay, excellent. And then what are the primary causes of male infertility?
So there are quite a lot of different causes of male infertility. In some cases, actually, we don't know what the reason is. We just look on the semen analysis and see that there's a decreased number of sperm called oligospermia, or there can be a problem with the motility or shape of the sperm. And in some cases, there's no obvious reason for this. There are some reasons that we do know. There's some lifestyle things that can affect sperm. So if people use alcohol in excess or smoking to excess, there are various types of toxins in the environment that can affect sperm as well. And also things like obesity and diabetes can also reduce sperm count. So there's some lifestyle things that can affect the semen analysis. And the other things that we know well about are genetic causes of sperm problems. These will be things, there are various different genes that can be affected that can do it. There's some called the Y microdeletions. There's a condition where there's an extra chromosome called Klinefelter syndrome. And sometimes there's the little tube that goes from the testis to carry the sperm is not present. That's called the vas deferens. So some people are born without that, and these are genetic causes. So a person could have genetic causes. There can also be acquired things that happen to you. For example, you get an infection that can block the tubes also between the testis and the penis. So that's an acquired thing, like a sexually transmitted infection. Can also cause to a person not being able to ejaculate sperm. And there's some patients who have severe treatment for cancer, like chemotherapy or radiotherapy, that will also damage the sperm cells. So many cancer patients, we would prefer to freeze their sperm before we do any treatment for them to make sure that we can help them afterwards.
Okay, great. So would you like to add anything to number 3 then, because you covered it quite substantially? What diseases can cause male factor infertility, if you'd like to add anything?
Yeah, I think in terms of medical illnesses, the main ones would be the sort of endocrine type of causes. And there are some conditions where people have got problems with their pituitary gland. And this is a condition that some men are born with, a thing called Coleman syndrome, where they don't have the little hormone from the pituitary that goes to the testis to tell the testis to make sperm. There's some people that have a growth on their pituitary gland called a prolactinoma. And that can be a silent thing where the person has no sperm, but if we measure their prolactin level, it's high. And it's quite an easy one to treat we can just give a medicine that blocks that, and we get sperm formation. So you can get some hormone conditions like that that can also cause problems with male factor infertility.
Thank you. Now, this is the one I might have a problem with pronouncing. So what is a varicocele? Varicocele. How does a man present with a varicocele, and can it be repaired?
Okay, so a varicocele is basically dilated veins around the testis. So basically, when sperm is produced, it is produced under conditions best when the temperature is a bit lower than body temperature. So your normal body temperature is 37 degrees, but the testes hang underneath the body, so the temperature is cooler, and sperm can be produced more effectively at that temperature. So if the testis is heated up, like somebody has a high fever, it can interfere with sperm production. And a varicocele with dilated veins around the testis can also heat the testis as well. And this can also cause problems with sperm production. So, and there's a lot of people with varicoceles. About 15% of the normal population have got a varicocele, and about 40% of men with infertility have got a varicocele. And the problem is, we're not, the evidence out there is not always clear about whether fixing it or repairing it, because normally a urologist will tie off those veins to fix the varicocele. The question is whether it will make a big difference, and some studies show benefit and some don't. So it's controversial whether it's always useful to repair a varicocele. So the American Urology Society, what they suggest is, if you've got a palpable varicocele, meaning it's easy to feel and it's very large, and the problem is only on the male side, so he's got a reduced sperm count, and the woman is otherwise fine, then it may be worth repairing the varicocele. If there's any problem on the woman's side and you're going to do IVF anyway, then there's no point in repairing the varicocele or evidence that it's going to be helpful. And if it's a very small varicocele or only visible on ultrasound, then it's best ignored as well and not operated on. So there's a certain group that you might want to operate on, but quite a lot of varicoceles you actually may not, you may just leave alone.
Okay, thank you. Then number 5, what treatments are available for sperm DNA fragmentation?
Okay, so let me explain what DNA fragmentation is firstly. So when we do a normal semen analysis, it's quite a basic test looking at the number of sperm and how many are moving and the shape of them. The DNA fragmentation test was an extra test to check the quality of the sperm. And what it's basically doing is looking at the genetic code and working out how many breaks there are in the DNA coding. And that gives an idea if there's been something called oxidative stress to the sperm. And this is bad for the sperm, and it causes the DNA to break up, and then the sperm can be less effective. And there's quite a lot of things that can affect DNA fragmentation. Things like smoking, also pyrexia, high fever can affect it. If a person is overweight, it can do it. Certain drugs like cannabis and so on also cause increase in DNA fragmentation. Varicoceles also do, also by the heating mechanism, increase DNA fragmentation. And yeah, any other kind of toxin that would be bad for sperm could also upset the DNA of the sperm. So it's basically an extra test that we can do. It's not an absolute test of whether the sperm will be functional or not. It's just another piece of information that we might get. So in a person that we're testing, we might go the additional step and do a DNA fragmentation test and then see, if it's abnormal. If it's abnormal, then we do have to look at their lifestyle and say, what can we stop? Can we stop the guy smoking, make sure he doesn't have any other medical illnesses and so on, which is affecting the DNA fragmentation results. Try and correct those and then repeat the test a few months later.
Great, thank you. Okay, when doing IVF or ICSI, is there a way to sort sperm according to DNA integrity and select only mature DNA sperm for fertilization?
Yeah, so when you're doing an IVF procedure, the first technique that was developed was choosing individual sperm, which is called ICSI, intracytoplasmic sperm injection. So the first thing they did in IVF laboratories when there was a problem with sperm was getting the ability, in the 1990s actually was when it was first done, where they could choose individual sperm and inject it into the eggs. And this revolutionized male infertility because we could now get couples pregnant where the man had very few sperm. So that was really the first step. And then since then, there have been other tests that people have developed. One is called IMSI, which is a magnification of the sperm. So you can take a sperm and magnify it 1,600 times. And this will help you look at shape of the sperm in a lot more detail and make sure that you're choosing correct sperm for injection into the egg. There are tests as well to look at whether sperm is mature and is more likely to actually fertilize an egg, and these things are called PIXI. And basically these type of tests are where you use you put the sperm in contact with either a human oocyte or even a hamster oocyte, and as a test, and you see whether the sperm can actually bind properly on the egg or not. So there's a few different tests that we do called hemizoner assay and hamster oocyte penetration test and so on that you can do in the lab to test the sperm. But in the laboratory, the most common one is probably the PIXI, where we're also just getting the sperm to bind onto the surface of an egg to select which sperm might be better, before we inject it into the egg.
Sure, very interesting. Thank you, doctor. Okay, now my husband has severe oligospermia, confirmed no blockage or varicose veins via ultrasound and X-ray. Fertility specialist has put him on Fertimid, aka Clomid, and includes various vitamins. Generally, we lead a healthy lifestyle, was never on testosterone. It has now been almost a year and still no change in his count. Is there anything else we have missed or that we could investigate to better his numbers?
Okay, so generally speaking, if you've got a low sperm count and it's under 10, the normal sperm test level is 15 million. So when they do the semen analysis, the way they work out what is a good number or not is they look at healthy people, healthy fertile controls. These are people that could have children, and they take 95% of the population and they say these are normal, and they take the lowest 5%. And all the test results are based on the lowest 5%. So if your sperm count is less than 15 million, it means you're in the lowest 5% of the population in terms of what would be considered a fertile control. And that's how the semen analysis sort of numbers are worked out. So if you're in that group, then you're called oligospermia if your sperm count is less than 15 million. And if it goes very low, less than 1 million, then we call it severe oligospermia. Now, if the sperm count is under 10 million, there's definitely a reduction in the chance of getting pregnant naturally. And a lot of those patients will need treatment, either with an intrauterine insemination or the IVF treatment. And, the intrauterine insemination, it doesn't work so well if you've got very low sperm counts, like under 5 million. But there are some recorded cases with 1 million motile sperm to inseminate and you can get a pregnancy. So we sometimes try it, but it's not the best technique. Mostly we want to do the IVF and inject the sperm in with the ICSI technique if the sperm is very poor. So generally speaking, if someone's got a very low sperm count, the correct treatment for them is the IVF treatment using ICSI. Now the question is, can you use medications to increase the sperm count? And it's quite complicated analyzing all the different medical studies on this to work out whether these medications work. Until recently, most of the publications said there was no role for using clomiphene citrate or Clomid to increase sperm counts because there wasn't sufficient effect. There have been a couple of studies just in the last couple of years which showed there might be a little bit of effect using clomiphene. But it's quite important that it works only in a very specific group of people, because the way Clomid works is it works on the pituitary gland and it increases the hormone FSH that increases sperm production. And it also increases a hormone called LH that increases the testosterone level in your testicle. So if you measure someone's FSH level in their brain and it's very high already, then there's no point in giving them clomiphene citrate because the FSH is high already. Yeah. And that's normally people who've got very poor sperm or very low sperm counts or no sperm. So if you've got a high FSH and very poor sperm counts or no sperm, there's no role at all to use clomiphene citrate. If your testosterone level is slightly reduced, then sometimes it does help to use clomiphene citrate and it might push up your level a little bit. But in a lot of the studies, the level still didn't reach normal levels. It just increased it a little bit higher than it was already. So it may be a beneficial treatment, but it takes a long time to work. You would have to look over about a year to see if there was a significant improvement. And, like I said, it works in a certain group. So you have to be very careful, to decide whether that patient's really going to benefit. And also if you've got enough time to put them on that treatment for a long time.
Thank you, Dr. Le Roux. Okay, then number 8, what would the solution be for this problem? So the diagnosis, left testis biopsy, hypospermatogenesis, if I said that right, epididymis and left tunica biopsies, fibromyxoid change. I hope I did that some justice.
Yeah, apologies for all the funny pathological terms the pathologists use. But essentially what we do is, if we have a patient who has no sperm in their ejaculate, so if they bring us a semen sample to us and we look and there's no sperm at all, we would first do some blood test, hormone test, and genetic test to see if we can figure out a reason why the person doesn't have any sperm in their sample. And we also sometimes take a urine sample because some people, the sperm goes backwards into the bladder instead of being ejaculated. So you would do those initial tests. And then afterwards, you actually do a biopsy on the testicle. So it's a small operation where we make an incision in the testis and we take out a piece of testicular tissue and look under the microscope and see what we can see. So in this particular case where they say a hypospermatogenesis, it means there is sperm actually in that sample, but just lower numbers than normal. So in that particular patient, their testis is making sperm, but lower numbers than normal and not enough that you can see it in the ejaculate. And that patient, we can normally help them because what we do is with that sample that we extract from the testis, we send it through to our IVF laboratory, and they use tiny little microscopic needles and break open the little tubules of the tissue, and they actually get the sperm out and then freeze it. And we can actually then, you know, the next month or whatever, for the woman, we would do an IVF treatment where we get eggs out from her, and then we can inject those individual sperm that we've recovered from the testis to make an, you know, to fertilize the egg and make an embryo. So if there's hypospermatogenesis, you can still proceed and do a treatment. In some cases, you will find no sperm at all. The sperm might have stopped in its development, and you only see very immature variants of the sperm. That's called maturation arrest. And then you don't have anything you can use there. And some patients, there's no sperm at all. They call it cell only because only the little tubules are there without the sperm. So in some cases, you can't find anything to use. But in this situation, it looks like there would be some sperm that they could freeze and then use for IVF. It's quite important if men go for testicular biopsies to try and do it in an IVF lab rather than just with a urologist and a pathologist, because this gives us ability of first looking to see what's there, but also freezing the sperm and using it so that the person doesn't have to go through 2 operations, one just to make the diagnosis and then to come back to another IVF unit again for the actual operation to get the sample for freezing.
Perfect, thank you. Okay, number 9, I had a vasectomy more than a decade ago, and now I wish to conceive a child naturally. Do I have any options?
Yes, so if somebody's had a previous vasectomy, there's basically 2 options for them. They can reverse the vasectomy. This is an operation normally done by urologists, and it's a microsurgical operation. The vas deferens is basically the tube that's going from the testis carrying the sperm towards the penis so that you can basically ejaculate the sperm. So when they do a vasectomy, they tie off that little tubule, and the one option is to reverse it. So their urologist will find the little tiny tubules and they'll microsurgically put them back together. And this procedure, it's probably will work in that you'll get sperm coming through probably in about 70% of the cases. The problem is that it's such a small little tubule, so sometimes even if you repair it, it just like scars and closes up again, and then you don't get any sperm coming through. So the one problem can be that it just fails, that operation, and then the other problem can be that some people, they seem to get antibodies in their sperm. So their body makes antibodies against the sperm after a vasectomy. And even if we get the sperm coming out, the sperm numbers can be quite low, and there can be antibodies, and then they're not able to conceive naturally. They would need IVF treatment. So basically, if someone's had a vasectomy before, the one option is going to try and reverse the vasectomy. And the other option is just going straight to IVF treatment, where we do a small operation where we just biopsy the testis, take some tissue out and freeze it. And 95% of the time, we're going to get viable, good sperm from a patient who's had a previous vasectomy. And then we can freeze the sperm and we just do IVF on the female partner, and then we can get a pregnancy. So it's a common reason that we do IVF. But a lot of patients will need IVF and not be able to conceive naturally.
Okay, thank you. And I think you mentioned one of them, but what are some causes of Oh no, hang on. What are possible explanations for a man's sperm count dropping to 0 after a vasectomy reversal procedure? And what are the next steps in this case? You covered some of that already.
Yeah, basically, so if you have a low sperm count after a vasectomy reverse, so if the doctors have tried to put that tube back together and you still have a low sperm count, it either means surgically the tube is not actually repaired, it's closed up again, or otherwise there's probably antibodies in the sperm reducing the sperm count. You know, and in that situation, we would basically do IVF treatment. We would just do a testicular biopsy on the testis itself, get the sperm out, freeze it, and then do IVF.
Thank you. Okay, what are some causes of sperm not maturing? What are treatments for this situation?
So, yeah, you know, when you do a semen analysis, basically you'll look at different, you know, aspects of the sperm. And a basic semen analysis is, you know, looking at the count and the motility and the shape of the sperm, the morphology. These days, what's quite interesting is we're using computers a lot more to analyze a semen analysis. So we use a system called CASA, as stands for Computer Assisted Semen Analysis. And this is quite useful because with the embryologist looking with their eyes at the sperm, you know, they have to make an impression of what percentage they think of the sperm are moving, for example, whereas a computer can actually pinpoint millions of little sperm and work out exactly how they're moving. Are they moving forward? Are they just twitching? Are they swimming around in circles? What are they actually doing? So computers have allowed us to analyze sperm a lot better than we could just with the human. So we're now using a bit of human intelligence plus the use of computers to give us a better understanding of what's going on with sperm. And there can be lots of reasons why sperm is not good. As I mentioned, sometimes lifestyle, sometimes there's an underlying disease that's causing a problem. And, you know, some of the more sophisticated tests like the DNA fragmentation can pick up perhaps the functionality of the sperm more than even a basic semen analysis. So, you know, the treatment options will be dependent a little bit on actually the final sperm numbers and movement, you know, as to whether you advise a patient just to adjust their lifestyle or whether they actually need fertility intervention like insemination or IVF ICSI treatment.
Okay, great. And we're on to our last one. What are the options for men who discover they have B+C microdeletion on their Y chromosome, resulting in Azuspermia, if a couple want to achieve pregnancy together without donor sperm?
Okay, so in some men, when they bring us a semen sample to us, there could be no sperm in the sample. We call that Azuspermia. And in those people, we will look for a cause to see why that is. And one of the interesting tests that we can do is we can test for a chromosomal gene problem in the male partner. So what we know basically is in men, you've got an X and a Y chromosome. Women are XX and men are X and a Y. And in the Y chromosome in the men, we know that there's a certain section of that chromosome where there's genes that code for sperm production. And they call it the AZF region, okay? And on that region, there can be different genes that are deleted. And the options are A, B, or C, basically, that can be deleted from that area. And what we find basically is if you get a deletion in the A and the B area, normally, if you go to theatre and you do a biopsy on the testicle and you take out tissue from the testis, you don't find any sperm. So if you have an A or B deletion, normally you can't find sperm when you do the testicular biopsy. If you've got a deletion of the C gene, then about 50% of the men, you can still extract sperm from the testis. So it can be a helpful genetic test for us to do before making a decision whether it's worth putting a man through an operation, the testis biopsy operation, to see if we can extract sperm. The other interesting thing about this particular, what we call Y microdeletions, where we pick up these genetic problems in the men that's causing no sperm, is even if we manage to do IVF and make a child for the couple, we know that if it's a boy, the boy will carry that same C microdeletion as well. So the child will be otherwise normal, but they also have a problem of sperm production. So we can help these couples, but we have to warn them that if they have a boy child, that he may have the same problem with sperm production when he grows up.
Okay, excellent. Sure, it's very interesting. Thanks, Dr. Le Roux. That was a really interesting conversation. So I really do appreciate you taking your time out of your day to give us this information. And I also want to thank Cape Fertility Clinic for your ongoing support of IFASA and all of our initiatives. You're always willing to give us a hand wherever you can. So I do appreciate that. And I also want to encourage the people watching this video to follow you guys on Facebook. You've got an Instagram profile as well. So it's good to do that from a patient perspective, because they can learn a lot from the things that are posted on your pages as well. So thank you, Dr. Le Roux. I really appreciate it.
It's really a great pleasure. I mean, it's been great chatting to you, and I hope that these videos allow patients to watch from their own living room and understand some things, and not be frightened to come to fertility clinics and seek assistance. You know, these days the clinics are very patient friendly, and you know, we want people to be comfortable and come along and seek treatment. And with modern technology, we can help many patients who couldn't be helped in the past. And I think it's wonderful that we do have these type of media functions on World Infertility Day, just to highlight it, because we know that there are many people out there that are struggling and are scared, and you know, these things allow them to, you know, understand that there are places that they can go to seek assistance. And you know, we obviously passionate about helping people to achieve their dream of having a child. So thank you very much, Saskia. I appreciate it.
Thank you, Dr. Le Roux.